Can you all see my screen?
Yes, thank you so much.
All right. Oh. How do I get this bar off of the top?
If you want to make it bigger, see the bottom where there's a scale on the bottom right. It says like 67%. You could just click the little book or click the little presentation. There it is. Perfect.
Okay. Sorry, the bar across the top cuts on right where I need to.
I totally understand.
All right. So again, my name is Allison Sela. I'm the medical director for intensive care and cardiopulmonary services at Mon Health Preston Memorial Hospital in Kingwood, West Virginia. And today I'm going to give a brief update on pulmonary rehabilitation, looking at some of the newer literature that's come out. Some of it I think I've introduced to this group before, and then there are a couple of new things that I wanted to make sure that we discussed. So, this is just a slide to remind you of the level of evidence that we have. The lowest level of evidence is our foundational, like our animal research, our ideas, our speculation. Going up from there, we've got specific case reports or expert opinions. And then up from there, we've got case series or uncontrolled cohort studies. And then at the top, we've got randomized control trials. And things like that. And because of the way that those studies are designed, it's going to give you a better level of evidence, something that you can be a little bit more comfortable with implementing with your patients. So the first study that I wanted to talk about are disparities in geographic access to hospital outpatient pulmonary rehabilitation programs. And so basically the premise of this study is that we know that our COPD patients benefit from pulmonary rehab. It improves outcomes in terms of their exercise capacity, severity of their dyspnea, and their health-related quality of life. But we also know that many people do not participate in pulmonary rehab. And so this particular study looked at the geographic distribution of their hospital-based outpatient pulmonary rehab programs, and looked at that compared to hospitals that offer pulmonary rehab programs and those that do not. And so what they found is that in 1,336 counties or county equivalents have at least one hospital outpatient program versus 1,776 counties that do not have a program. The availability of pulmonary rehab programs was significantly more prevalent in metropolitan counties versus non-core counties or rural counties that only had about 27% of counties with programs available. And I think, we see that a lot, and that's part of why this group exists, is because we do have a disparity of pulmonary rehab within our states. And then also hospitals that are designated as critical access hospitals or hospitals located in the South and West were less likely to have an outpatient pulmonary rehab program. And you can see with this graph here, the percent of hospitals that have pulmonary rehab programs available. You can see the gold color are the states that have more than 75% of counties with outpatient pulmonary rehab programs, followed by the gray, which is where we fall in, where only we're about 51 to 75% of our counties have it, or hospitals have it, which is actually pretty good. And then down into the red, where only less than 25% of outpatient hospitals have programs. So what they recommended is for some solutions, educating the clinician and the patients of the benefits of pulmonary rehab, offering incentives to supervise and provide these programs, improving reimbursement rates, looking at these successful rural programs that we have and trying to model programs after those, taking programs that have cardiac rehab and expanding those to include pulmonary rehab, which I know a lot of our sites within this particular group started with pulmonary rehab and expanded to cardiac rehab. My site at Preston Memorial is actually the opposite. We started with a cardiac program and expanded to pulmonary. And then also using telehealth. And we'll get into a little bit more of the data and the research on telehealth later in this presentation. The next set of studies look at acute exacerbations of COPD, and previous reviews that were mostly randomized controlled studies have been shown to reduce hospital readmission rates for acute exacerbations of COPD. The cohort studies have been less consistent that has been beneficial. And so what this study aimed to do is compare the rates of hospitalized and general practice treated acute exacerbations prior to and following pulmonary rehab. And so they looked at hospital admissions and clinic visits for 1 year prior to enrollment in pulmonary rehab and 1 year after pulmonary rehab, and patients that were referred for pulmonary rehab. So they weren't necessarily patients that participated, but were at least referred. So what they found is that 64% of patients were eligible for pulmonary rehab, but only 9.3% were referred. 89.8% were not referred. And then of those that were referred, less than 1% declined referral, which was pretty surprising to me because I have a lot of patients that don't want to participate. But so patients who were referred had a slightly higher but not a statistically significant exacerbation rate than those who were eligible but not yet referred. And so what this study found is that there were not fewer COPD exacerbations in the patients that were referred for pulmonary rehab. So this says nothing about pulmonary rehab and the effect that pulmonary rehab had. It just has to do with the referrals for those patients. The thought behind this is that pulmonary rehab did not affect the frequency of inflammation and infectious events. You know, these people were still going out in public. They still had this inflammation. Nothing that we do in pulmonary rehab is going to decrease that. But what we do know is that pulmonary rehab leads to reduced severity and better management of our exacerbations. So these patients have changes in their dyspnea, their physical conditioning, as well as enhanced disease knowledge. So they're able to better manage these exacerbations if they do happen. Now, this study was a UK study that looked at pulmonary rehabilitation for COPD patients. And what they were hoping to prove is that completion of a pulmonary rehab program was associated with a reduced risk of hospitalization and time spent in the hospital. With this study, 24% of patients who completed their program had at least one admission for COPD exacerbation versus 38% of patients who did not complete a program. Those who completed the program had an average of 4.8 bed days versus 9.6 bed days. Their 90-day mortality was 0.1% versus 1.6%. And their 180-day mortality was 0.5 versus 3.2. So they also found that those patients that attended more sessions or longer programs had a larger reduction in mortality and some of these other consequences. Again, getting the patients in these programs does tend to show mortality benefit, and that's one of the big driving factors for supporting these programs and getting them into all these hospitals and outpatient programs as well. Sorry. Supervised maintenance. This was a meta-analysis of randomized controlled trials that looked at the addition of a supervised maintenance exercise program following the initial pulmonary rehab program. And what they found is that it decreased the risk of hospitalizations for respiratory causes, as well as exacerbations requiring treatment. So all those numbers were down when patients participated in a maintenance program. This is a newer study. It was just published last year. It was a 5-year prospective cohort study that assessed the yearly evolution and outcome. They looked at 6-minute walk. They looked at health-related quality of life and dyspnea. And they looked at a supervised self-help PR maintenance program for COPD patients. And the aim was to assess the change in outcomes and the survival probability for a period of 1 to 5 years after the program, after discharge from the program for COPD patients. And they looked at 144 patients annually for 1 to 5 years. And they found that patients with a maintenance program showed significant benefits at 4 years for 6-minute walk distance and their VQ11, which is a symptom score. It showed benefits at 5 years for the MRC symptom score. The 5-year survival probability was higher in this group of patients that participated in the maintenance program than patients that just completed a pulmonary rehab program without maintenance. So they had a better survival. And they did notice that there were 2 different clusters. And the patients that seemed to respond better and to show more of these long-term benefits were the patients with less severe COPD. So the conclusion from this study is that a longer maintenance program was found to be beneficial, especially in less severe COPD patients. And this is pretty interesting because the previous studies and the previous research that I had seen, they looked at a rehab program really in the short term for about a year afterwards, and they saw benefits for 3 months. And a lot of the studies showed that by 6 months and 1 year, there were no longer benefits. So for this study to show that there were benefits at 4 and even 5 years out after the completion of pulmonary rehab is really, something I think we need to take back to our patients and try and encourage them to continue to participate in maintenance programs. And I know we have several patients in my program that are COPD and Black lung patients that have been participating since we started the program. And so, we continue to see them show benefits and complain of fewer symptoms and have fewer exacerbations. So to have a study that actually proves that what we're seeing is what they're seeing nationally is pretty significant. So I was happy to come across this study. We also know that pulmonary rehab does help with symptoms of anxiety and depression in COPD patients. This study was a systematic review and a meta-analysis on randomized controlled trials comparing pulmonary rehab of at least 4 weeks duration with usual care. Looked at 11 studies that included 734 patients. They compared usual care to pulmonary rehab, and they found that pulmonary rehab did show significant benefits of a moderate magnitude for anxiety and a large magnitude for depression. And so what they found is that it was at least 4 weeks, but beyond that, there wasn't a whole lot of change. But there was some improvement. And, I think a lot of you that work day in and day out with these patients know that when patients get this diagnosis or when patients are put on oxygen or have other significant setbacks, it does really contribute to their anxiety and their depression. So getting them enrolled in a pulmonary rehab program can definitely help mediate those effects. This study looked at inspiratory muscle training. There were two studies. They looked at adding inspiratory muscle training to pulmonary rehab, and they looked at increasing maximal inspiratory pressure. It was not a clinically significant benefit. It really did not provide any additional benefits in terms of exercise capacity, quality of life, or dyspnea. So not really something that is recommended as an addition to your program. There's lots of other things that you can do instead that have been shown to provide benefits for these patients. This particular study looked at Tai Chi, which combines psychological treatment and physical exercise and requires no special equipment. And their hypothesis is that Tai Chi is equivalent to pulmonary rehab. And by that, their definition was that there was a difference of less than 4 St. George Respiratory Questionnaire points, which is a quality of life scale. So they looked at 120 bronchodilator naive patients, and 2 weeks after receiving Indacatrol 150 micrograms once daily, they randomly received either standard pulmonary rehab 3 times a week or Tai Chi 5 times a week for 12 weeks. The primary endpoint was a change in their St. George Respiratory Questionnaire prior to and following intervention. And they also made measurements at 12 weeks after the end of intervention. Just briefly, the St. George Respiratory Questionnaire is a 50-item questionnaire, measures health status, quality of life in patients with diseases of airway obstruction. It looks at 3 different categories: symptoms, activity, and impact, like psychosocial symptoms. And then there's also a total score. If you have a change of 4 units, that is considered statistically significant. So what they found is there was a difference exceeding the minimally clinical important difference. At 12 weeks later, the between group difference favored Tai Chi, and they concluded that Tai Chi was equivalent to pulmonary rehab based on this study. Now, this study used active farmers as their subjects. Okay, so we've got patients that are already active. Their 6-minute walk test distance was 537 plus or minus 65 meters, and they walked close to 8,000 steps a day. The Tai Chi group received instruction 5 days a week versus the pulmonary rehab group only received instruction 3 days a week. The Tai Chi group was encouraged to continue Tai Chi after completion, whereas the pulmonary rehab group had no maintenance program, no supervision beyond verbal encouragement to remain as physically active as possible. And so it should be noted that there was no practical change in 6-minute walk distance in either group. Only the St. George Respiratory Questionnaire changed, and that could be related to other factors such as social component, expectations, or investigator attention. So although this study did prove that Tai Chi was better or at least equivalent to pulmonary rehab, it was a flawed study. There was a lot of differences between the groups as far as how they were treated, what type of attention, and how the program was structured for them. So take that with a grain of salt. Now, the nice thing that I talked about at the beginning is that Tai Chi does not involve any equipment. And so for some of our patients that are unable to get out of the house and unable to come to a center for pulmonary rehab, may this be beneficial for them? It's possible, but again, remember, these patients were walking 8,000 steps a day, and I don't know how many of your regular pulmonary rehab patients are getting 8,000 steps a day at baseline. So just something to keep in mind. The next set of studies looked at home-based physical training. This study looked at patients who need long-term oxygen therapy because they have difficulty participating in these outpatient programs. They have an increase in severity of disease oftentimes. There's transportation limitations as well as mobility limitations. There are sometimes high costs associated with coming to a center for pulmonary rehab, depending on insurance issues, and then issues related to patient safety and other individual needs that they may have. So this study looked at the effectiveness of a supervised home-based physical training program on exercise capacity in patients with COPD receiving long-term home oxygen therapy. So COPD patients on oxygen, and how did their home program do? So they were divided into two groups. They had a supervised group and a home-based supervised muscle strength and endurance training. This supervised group received home-based muscle strength and endurance training. They meet twice weekly for 60 minutes for 12 weeks. And then the other group was unsupervised, and they were given a book with some exercises in it. So I'm sure most of you can see where this is going. So only the patients who had supervised physical training showed an improvement in 6-minute walk distance in the Medical Research Council scale, the Brazilian Portuguese version of the fatigue severity scale, and their COPD assessment test. Again, if you hand a patient a book and say, here, read this and do this, and then there's no follow-up and there's no accountability, people are not going to necessarily do what they need to do, versus making them log in, watching them do the exercises. They're going to show a better compliance with that, and then hopefully a better result. This study is another new one that just came out last year, and this one looked at online versus face-to-face pulmonary rehabilitation for COPD, which is something that we've all been dealing with, how to manage this and which route to go for the last 2 years. This was a 2-armed parallel single-blind randomized controlled trial. The online arm carried out pulmonary rehab in their own homes, and the face-to-face group was in a local rehab facility. There were 90 patients with the diagnosis of COPD. Their MMRC score was 2 or greater, so they were more symptomatic, and referred for pulmonary rehab. They were randomized in a 2-to-1 ratio to online, which were 64 patients, or face-to-face, which was 26 patients. Patients were unable to use internet-enabled device at home were excluded. The main outcome measurement was 6-minute walk distance and the CAT, the COPD assessment test score at the completion of the program. So the adjusted mean difference for the 6-minute walk test for the intention to treat population was 23.8 meters, and the CAT score difference was -1 in favor of the online intervention. And so their conclusion to this study is that pulmonary rehab is evidence-based and guideline-mandated intervention. A 6-week program of online supported pulmonary rehab was non-inferior to a conventional model delivered face-to-face sessions in terms of effects on 6-minute walk or symptom scores, and that it was also safe and well tolerated. So this was good to see for those of us that had patients or still have patients that don't want to come into the hospital or can't come into the hospital, that if we provide the right type of program for them online, hopefully, they won't be losing out on much as far as the 6-minute walk distance and symptom scores are concerned. So in summary, there is a significant geographic disparity in access to hospital outpatient pulmonary rehab. The concerning thing is that less than 10% of eligible patients are referred to pulmonary rehab in one specific study. There was a recent study that showed no difference in exacerbations in patients participating in pulmonary rehab. That study is really not common. Most of the studies that we see have shown that there is a benefit and a decrease in exacerbations for patients that participate. So it was sort of shocking when that study came out. A UK database showed a reduction in hospitalizations and hospital days in patients completing pulmonary rehab. This study is more along the lines of what we continue to see in published studies, is that we are making a difference. There is a benefit. We can keep people out of the hospital. We can have them in the hospital for a shorter amount of time. We also saw that supervised maintenance does decrease their risk of exacerbation and decreases their risk of hospitalization. The new study looked at long-term maintenance program, and we did see a benefit in these patients for up to 5 years. Again, pulmonary rehab does have a moderate effect on anxiety and a large effect on depression. Inspiratory training did not really have a clinically significant benefit on maximal inspiratory pressure. The Tai Chi study showed that it was equivalent to pulmonary rehab, but again, there were some design flaws and disparities with this study, so take it with a grain of salt. And then finally, home-based physical training has been shown to be effective if supervised and was not inferior to face-to-face programs, which is good in the COVID era. And then I've got my references if you need them. And that's what I have. I'm happy to answer any questions. And if not, I'll turn it back over to Elizabeth.
Thank you so much. You did a wonderful job per usual, Dr. Steele. I really appreciate your time. It was excellent. Does anybody have any comments or questions? All right. Well, thank you very much. I will provide those slides from Dr. Sela, and we'll go ahead and go to the case presentation. Is your computer up and running on your end?
Yes, we have a functioning computer now.
No worries. Would you like me to share the slides, or would you like to on your end?
I'll share the slides. I just need permission.
I did. I think it works. So let me know if it didn't.
Awesome. Another question mark. Can you see it okay?
Yeah.
We have two screens here, so I have confirmation that we can see it right. Alrighty, my name is Bhanu Saumya Purugamarugu. I go by Bhanu. I'm one of the first year fellows at WVU University, and I have Dr. Balakrishnan with me.
Hi everyone, I'm Priya Balakrishnan. I'm one of the pulmonary faculty. Sorry about this morning's computer snafu. Are you all seeing the right screen? The presentation, are you seeing the overview?
I can see it. It's just smaller. Or can you guys see it? Or is it
like
just
on the presenter screen, I think.
Just switch the very beginning.
Again, guys, apologies for the
No, you're fine. No worries at all.
how about now?
No, you see the screenshot needs to be, the green tab has to be on that side. Makes sense. Yeah, so the first one on your top left.
There we go.
Perfect. Jinx.
All right. Hopefully no more technical difficulties. All right, so we'll be talking about chronic thromboembolic pulmonary hypertension in brief with a case presentation. If you have any questions, please feel free to interrupt me. All right, and we have no disclosures. The case presentation, we have a 65-year-old male. He had progressive dyspnea at rest, which eventually progressed to exertion for over 8 months period. He had a hospitalization about 8 months ago before any of this started for an acute PE and bilateral DVD. He received anticoagulation. His echocardiogram showed right heart strain pattern. He has elevated BNPs, troponins. So he was treated with anticoagulation and discharged home on 2 liters nasal cannula and Eliquis, and he's now presenting to us requiring 8 liters of oxygen on exertion. A little bit about his past history. He had a provoked DVT following knee surgery, orthopedic surgery several years ago. Hypertension, anxiety. He had no family history of bleeding or clotting disorders, no history of malignancies, and social history wise, he had a 20-year smoking history, and he quit 7 years ago. Social history wise, he was a long distance truck driver as well. That puts him in a high risk. On examination wise, he was morbidly obese with 44.77 BMI. Heart rate was 70 beats per minute. He was saturating 90% on 8 liters oxygen levels in cannula. And his lungs were clear to auscultation, but he was noted to have pedal edema bilaterally, left more than the right. So one of the things that we were concerned when he presented to our clinic is he had acute PE 8 months ago, and he received anticoagulation. Now it's been about 8 months, and he continues to have dyspnea. He continues to have hypoxia, and that's probably not a normal, natural progression of pulmonary embolism. Usually, it should resolve within 3 to 6 months. A clot resolution should happen, and if it persists, then that makes us wonder, what's going on? What is other things that we should be considering in our differential diagnosis? So going over the differential diagnosis of dyspnea, it's pretty vast, right? It pretty much involves multiple systems. So in chronic dyspnea, which is what we would consider this patient would have, it could be, lung related, like asthma, COPD, ILD, sarcoid, C. diff, arrhythmias, the list goes on. In this patient, since we had a, history of acute PE, and then requiring persistent O2, and the BMI was elevated and the patient was Eliquis, we were concerned that this patient received adequate anticoagulation, with this patient having chronic thromboembolic pulmonary hypertension. That led us to the further workup. So a little bit just about pulmonary hypertension. It's about affecting 1% of the global population. And you can see that the pulmonary congestion and the post-capillary pulmonary hypertension and the pulmonary vascular resistance over a period of time, the higher the number, the higher the risk of mortality and, leading to right heart failure as well. And clinical classification wise, we have 5 types: pulmonary arterial hypertension, pulmonary hypertension associated with left heart disease, pulmonary hypertension associated with lung disease, and then the 4th one, the pulmonary hypertension associated with pulmonary artery obstruction, and that's where the CTEP comes in the picture. And pulmonary hypertension with unclear or multifactorial mechanisms. So some of the symptoms they'll have is dyspnea on exertion, fatigue, dyspnea when bending forward called bendopnea, palpitations, hemoptysis, exercise-induced abdominal distension, nausea, weight gain, syncope. And a very severe conditions where late presentations, they can also have exertional chest pains, hoarseness or dysphonia, wheezing and respiratory tract infection, atelectasis, etc. And some of the signs of pulmonary hypertension on physical examination, you can see a distended pulsating jugular veins, abdominal distension, hepatomegaly, ascites, peripheral edema. They can also have peripheral cyanosis, dizziness, cool extremities, and prolonged capillary refill. So on the echocardiogram, there are some certain, like there are a lot of findings that you can see, but most of the ones that we can easily visualize on a focus device is an enlarged right ventricle on a parasternal long axis view. And this is the first image here. You can also see like a dilated RV to LV ratio. As you see here, the RV is supposed to be smaller in sense. It's a lot more bigger. And you might also see this being reported in the echocardiogram and also in CT scan images saying that the RV to LV ratio is like greater than 1. The flattening of the interventricular septum, which is also called as like the D shape, that's another one, and also distended IVC with diminished inspiratory collapsibility. Why is like RCDEF important? Because there are like a lot of trials going on for the treatment of pulmonary hypertension. And for type 4, like surgical therapy, which is a pulmonary endarterectomy, is actually shown to be mortality benefit and also improves functional capacity of the patients. And it's like a definitive treatment. And that's why it's essential for us to identify it early and also refer the patients appropriately for adequate treatment. And the other options that we have are BPA and also some medical therapy with medications. So a little bit about chronic thromboembolic pulmonary hypertension. Incidence is about 2 to 6 cases per million and prevalent like 26 to 38 cases. It's a type of pre-capillary pulmonary hypertension. The reason why this happens is because of incomplete resolution of the clot, PA obstruction, and associated microvasculopathy. And these are some of the pathophysiological mechanisms that can happen. So a lot of factors play into a role for an acute pulmonary embolism to progress into a chronic thromboembolic pulmonary hypertension, such as like size of the initial thrombus. If the size was like really huge, that can like progress, delay in the anticoagulation. RV strain at the diagnosis is also like shown for patients with acute kidney to progress into CDEF. And then of course, like impaired fibrinolysis, inflammatory process like inflammation in the thing, impaired neutrophilic response, and also impaired angiogenesis, monocyte response. All of these can lead to remodeling of the emboli and eventually progress. Some of the risk factors, like we already discussed, recurrent PE, large perfusion defect, higher PA pressures at the time of initial diagnosis, and unprovoked or idiopathic PE. Hemostatic risk factors, especially APLA, lupus anticoagulant, and then associated medical conditions. Usually see patients with like splenectomy, VP shunt, hypothyroidism, sepsis, or if they have like indwelling catheters, that also puts them at a higher risk of developing CDEF. So what are the diagnostic workup that we can use whenever you have signs and symptoms of pulmonary hypertension in the setting of VTE or no VTE? So always get, like basics. Let's find out what is the cause of this patient's dyspnea. Chest radiography to see if there is any pneumonia or any pneumothorax, atelectasis, and pulmonary function test to see if there is any obstruction or restrictive pathology that's present. An echocardiogram can give us a lot of information too, if there's any right heart failure signs in there, if there is any arrhythmias present. And echocardiogram can give us a lot of information. Most of the time, as a resident, I used to often look at the ejection fraction, if the patient has left ventricular failure or not. Now we have like progress towards looking into more details, such as what's the size of the RA, what's the size of the RV, what's the size of the LA, has it enlarged, and how about the TR jet? Is there any like a significance of like pulmonary hypertension there? Is there a evidence of right ventricular failure, etc.? So echo can play a huge role. To screen, we need what is called as ventilation perfusion scan. That is a screening test for CDEF. It has an excellent sensitivity and also specificity. It has almost like close to 100% specificity. If the VQ scan is negative, does not show any ventilation perfusion defect, then we can pretty much rule out PE at that point. And then abnormal, if you find that VQ scan is abnormal, then you have to like go into details. Like some of the tests that we can do is catheter-based pulmonary angiography, then CT pulmonary angiography, MRI, and right heart catheterization. So right heart catheterization with the catheter-based pulmonary angiography together will give us the best picture, because one, we can identify exactly where the clot, like how much is a clot burden. And with the right heart cath, we can tell that what type of pulmonary hypertension it is and what's the burden even before going for an intervention. So a little bit about treatment options. We have pulmonary thromboendarterectomy, which is the treatment of choice. I can play a quick video. So basically in this, the way they do this procedure is mid-sternotomy. They have to put the patient on a bypass, basically to create a bloodless field. And then they will like cut open the pulmonary artery, go in and literally scrape out the clot from the intima layer. So that's and it's done like at a time period of like 20 minutes. They'll finish one side and then rest, like rewarm the patient and then go back to the next one, and then they'll remove the clot. So it's a pretty extensive procedure. It's come a long way. It was associated with, like a lot of mortality, but now actually the benefit and also the risks of complications have like drastically decreased. Some of the complications that can still happen is arrhythmias, pericardial or pleural effusion, atelectasis, wound infection, delirium, reperfusion, pulmonary edema. That's another thing that can happen. And outcomes usually 5-year to 10-year survival of like 82% and 75%, and in-hospital mortality of 2.2%. This was based on the San Diego study. And they also have improved hemodynamic parameters, functional status like the NYHA class improvement, and also remodeling of the right ventricle has been like the progression of remodeling has decreased. So definitely has shown a significant improvement, and that's why it's like the gold standard treatment of the treatment of choice. And balloon pulmonary angioplasty, this was another intervention that was actually studied several years ago, but then because of increased complications, the techniques, it was kind of like not encouraged, but then people went back again and they're like a lot of studies being performed right now. And this is basically revascularization of multiple vessels. It's not like endarterectomy where you go in and you do it one job and then next you see improvement in patient symptoms. In this, it's more of multiple sessions because you have to go in and, extract the break the blockage and then come back and go back in, break the blockage, come back. So it's a multiple settings. The symptomatic resolution does not appear right away. It takes several weeks for them to have symptomatic benefit. It's sometimes used as a bridging before PT. It has shown promising results in the recent studies. And they're currently working towards how about giving them in patients, especially who are inoperable, who cannot get pulmonary thromboendarterectomy. Can we give certain medications and then do BPA, and does that show an improved benefit versus just doing BPA alone, etc.? That's called like a race 2 trial that's going on. So, and then complications, again, these patients will have reperfusion injury and also pulmonary vascular injury. Medical management. So the only drug that's been approved by FDA is the riociguat, which is a soluble guanylate cyclase inhibitor. The just one trial, about 261 participants, and they showed that significant improvement in the pulmonary vascular resistance and also 6-minute walk distance at 16 weeks. The other one was the bosentan, which is the benefit trial. This was also double-blind randomized placebo-controlled study. It did decrease the pulmonary vascular resistance, but did not show much benefit with the 6-minute walk distance. And macitentan is the other study that's a phase 2 trial, basically included 80 patients. And in this as well, the basically 6-minute walk distance improved, but then not much with the peripheral vascular resistance. So riociguat, some of the common side effects are headache, dizziness, hypotension, anemia, vomiting, nausea, GERD, and contraindications of pregnancy. You cannot co-administer this with another phosphodiesterase 5 inhibitor, and also pulmonary hypertension with idiopathic interstitial pneumonia. So just a quick summary. So we have surgical options, BPA, riociguat, vitamin. So in all these patients with chronic thromboembolic pulmonary hypertension, they need to be anticoagulated because the risk of recurrent thromboemboli is higher. And if it happens, and there's risk of worsening of the remodeling process as well. So that's the reason why we have to make sure that these patients are on anticoagulation. Now, one of the challenges that comes is the BMI. So use of DOACs in patients with BMI greater than 40 is not very well studied. It's still, like the efficacy, we still don't know. So in those patients, vitamin K is a preferred option. And as you know, in our patient, his BMI was actually 44.4 and he was on DOAC. So maybe he never had a therapeutic dose of anticoagulation. Then morbid obesity limits the use of DOACs, like I discussed, and encourage patients to exercise and always need a multidisciplinary approach for this patient and frequent follow-up. So this is like the primary treatment for CTEP. For right heart catheterization in 3 to 6 months after an intervention to see whether there is improvement in the hemodynamic parameters. Echocardiogram can be done annually, 6-minute walk distance and exercise capacity annually. Then there are some scores that you can use for risk assessment, as far as REVEAL risk score. And ultimately our goal is for functional improvement. Hemodynamics should be like monitored, and improvement of those hemodynamics on the right heart catheterization in 3 to 6 months, and ultimately improvement in the quality of life. And this is a REVEAL risk score that we often use in the clinic for these patients. So it's available on the PH Initiative website on the internet. You plug in the points, whatever information you have available at that time. And then low risk is basically 0 to 6, intermediate risk is like 7 to 8, and high risk is more than 9. So let's continue with the case. So we did further workup when the patient came to our hospital. We noted that initially when the patient came, the BNP was elevated at 493. Patient was on Eliquis, and we looked for anti-factor 10A levels in the plasma. Or like basically when the patient is on apixaban, the level should be low because we are like inhibiting it, but it was like pretty significantly elevated, suggesting that maybe this patient failed the Eliquis treatment. PFTs showed normal spirometry, except for DLC was like mildly reduced. Sleep study showed no significant sleep apnea. There was significant hypoxemia at night that was noted, and VQ scan showed several mismatched perfusion defects. The reason why we did all these studies is to basically rule out other causes that this patient might have, like other causes of pulmonary hypertension. This is the VQ scan that we got. As you see here, so basically the first image that you see here is the ventilation, and the second here is the perfusion. And similarly, ventilation, perfusion for the right and the left. So normally on these scans, it's all supposed to look black, right? But if you see here, it's not really. So the ventilation here, you see a little bit of black here, but then here it's more grayish, means there's a perfusion defect. It's not really getting perfused. And if you look at here, it's pretty much like gray. There's absolutely no perfusion. There's a little bit of ventilation happening, but then absolutely no perfusion. So that tells us that there is a mismatch between the ventilation and the perfusion defect. And this is the CTA chest. So this is acute P when the patient had in like 2020. So you can see here, it's a huge clot. Sorry. It's a filling defect that you can note. Sometimes I leave it. All right. And this is for the chronic thromboembolic pulmonary hypertension. Here also you see filling defect, but it's much more like, it's like almost attached to the wall, unlike in acute PE. See this? It's like completely occluded, whereas on this image here, it's like almost part of the wall now, and that's why it's much more challenging to manage these patients. All right, and this is the echocardiogram of our patient when they came to us in 2021, 2023. You see there is interventricular septum here, like the right ventricle is like much more dilated when compared to the left side. Yeah, the size is like almost the same. So that's why we say like almost the ratio is like equal to 1 or like greater than 1. Suggestive of some right heart strain. And this was a right heart catheterization that we did for our patient. So if you look at the wedge pressure here, the mean pulmonary arterial pressure was 33, that is elevated. And then the wedge pressure was 12, that is basically normal or low. And PVR was 2.5. So basically for right heart catheterization, for our, like to diagnose like CTEP, you want a mean pulmonary arterial pressure like elevated, and the wedge pressure should be normal. The wedge pressure is high, that means like it is left heart, like probably heart is involved as well, that means post-capillary involvement as well. But in this patient, wedge pressure was low. And then PVR should be again greater than 3. In our patient, PVR was 2.5. That means that maybe the rebonding process has not begun yet. So that's what we were like going towards. And this is the right heart cath. As you can see, there is like literally no, it's like the perfusion is like significantly decreased on the upper lobes. And this is like something that you can like classically see. So just a little bit of clinical progression. So October 2020 is when the patient had acute PE, right heart strain, and also had DVT. April 2021 is the first time they were like following up primary care physician. They came to us for the first time in April 2021. And we noticed a significant increased requirement of oxygen to up to 8 liters and also dyspnea. So we did an entire workup and then we diagnosed him with CTEP. So given the gold standard treatment is endarterectomy, we discussed the option with him, but the patient like opted for medical treatment and not surgical intervention. So the patient was switched to Coumadin and then was given Rehab as a bridge treatment, and usually the dose is 1 milligram TID, and then as they tolerated, the dose is increased. This patient had also lost by that time about 20 pounds, and then the 6-minute walk test at that time was 304, and then reveal score was 5. And patient hypoxia 3 liters at rest and 8 liters on exertion. And as you see, like between April to June, might be wondering like why there is a treatment delay. That was because patient was initially sent to the hospital. It took some time to get the right heart catheterization, and also some time for the medication to be approved by the insurance. So all these nuances in between. And then in July, the patient was followed up again. The Rehab dose was up titrated. Oxygen requirement was coming down. It's now like 6 liters. Patient was encouraged to like exercise and also lose weight. In August 2021, almost like his oxygen requirement came to 2 liters, and at room air, at rest, he was pretty much on room air. Like he basically took oxygen off himself, and then like reveal score was 4, and 6-minute walk test was 263 meters. In like October 2021, like he was still requiring O2 at exercise, and his 6-minute walk distance was like 300 meters. But his dyspnea continued to persist. And that's when we were like, let's refer him to another center to see if we can do a pulmonary thromboendarterectomy. And this was, I just like followed his chart on the clinic again. So basically he had a right heart cath done in February of 2022, and they noticed that the mean pulmonary arterial pressures decreased to 27. He's on diuretic now, and CPET is also suggestive of pulmonary vascular disease. Coronary, they did a cardiac cath on him and was noted to have coronary artery disease. So in July, he underwent both pulmonary thromboendarterectomy and also CABG procedure. Right now, he's participating in the rehabilitation facility and currently requiring 2 liters oxygen on exertion. His NYHA is class 3 because he just had a surgical intervention a few weeks ago. So again, like emphasizing on the multidisciplinary approach, pulmonologists, interventional radiologists, cardiologists, rehab facility, physical therapists, pharmacists, like everyone play a huge role in patient improvement. Again, I would like to thank the WVCTSI Project ECHO CLD team and also Dr. Stansbury for giving us this opportunity to present here. If you have any questions, feel free to answer.
Excellent job. Thank you so much. That was a very thorough look and everything, and including that case. You guys, that was well put together, and the imagery was really, really good. So we really appreciate that. I think it gives people more of a picture of what's going on. Does anybody have any comments or questions?
I have a question for actually, that, I agree, that was a great presentation. Thank you, Dr. Balakrishnan. We kind of got a double feature today with two didactics in one case. So that was pretty great. This was 2 in 1. I had a question for Dr. Sela. When she was presenting, I was in the car just listening, so I couldn't see the slides. But that study where there was I believe it was something like 8% of patients got referred, and then you said that 99% of the people referred did pulmonary rehab, if I heard that correctly. And that makes me think that the definition of referred in that study was different than what we would ordinarily think of. And I suspect that, so I can't, I'm anxious to look at your slides because I have to give a talk on this very same subject to the West Virginia Respiratory Care Group, which is basically the West Virginia AARC chapter at Glade Spring this Friday. So I've been trying to look at the same exact studies that you have, Allison. But my hunch is that usually we think of offered, enrolled, and graduated. And enrolled is the same thing as intake. And it almost sounds like in that study, referred and intake. Referred means they got there and they actually got an intake, rather than what we would think of just somebody in the hospital offered them pulmonary rehab. Because there's no way that 99% of people who are offered pulmonary rehab get it. When you look at that study, does that sound right to you, or what do you make of that anomaly?
I was shocked by those numbers myself because, like I said, I know my refusal rate is much higher than that for patients that I refer to pulmonary rehab. I'd have to go back and look at that particular study because it's been over a year since I looked at that one. And I can't remember what their definitions were. But my initial thought, and my thought still every time I see that statistic, is I'm shocked, just because that number is so low. But I think, part of it is selection bias. I think the people that are getting these referrals to pulmonary rehab are the people that keep ending up in the hospital, the people that keep having exacerbations. And I think for that reason, I think the patients are as frustrated, as we as clinicians are. And so maybe that may have skewed things a little bit towards, them saying, yes, fine, do whatever I can do to make me feel better. Now, at the same time, Terry's on the call and she'll tell you that I send her referrals for patients all the time. And they are more than happy to look me in the face and say, yeah, sure, I'll go to pulmonary rehab. And when she picks up the phone to call them for their intake, they're like, no, I don't know what you're talking about. I'm not interested in doing it. I'm not coming. I don't want to do it. So, it could just be that aspect as well, that the clinician has said that the patient accepted their referral, and then by the time they got to pulmonary rehab, they've changed their mind. So again, I'd have to go back and reread that study because it's been a while since I read that one, but I can certainly do that and get back to you on that, or give you that resource.
Thanks. We think what we have seen at New River and Cabin Creek is actually something like more like 1 in 10 that in terms of us offering pulmonary rehab and people actually committing and showing up. Unfortunately, it's somewhere more like 1 in 10, which goes a long way to explaining why only 5 or 3% of people in the country who are eligible get pulmonary rehab. It does have a lot to do with the effort it takes to actually make the commitment and show up.
Wow, thank you so much. It's really interesting. And then I think in the chat, Terry said, yeah, this happens a good bit. I think the patient says what they think the doctor wants to hear. Thank you. Does anybody else have any questions before we end the session? All right. Well, again, thank you guys so much. Thank you for the case. Thank you, Dr. Sela, for the didactic, and thank you for the questions and comments. Our next session will occur on October 3rd with Dr. Sela discussing COVID-19 and the lungs. And so I hope to see you guys soon. Have a great week. Thank you.